Welcome back to Decode Healthcare. I'm Harshal. Today's explainer is all about medical decision making, or MDM. Specifically, we're tearing into Element 1, the number and complexity of problems addressed. If you're following the latest E&M coding guidelines, you already know your entire code hinges on this. Let's master this first element right now.
Here is our roadmap for this explainer. First, we'll define the problem addressed. Second, we'll look at the 4 problem tiers. Third, we'll get into key definitions and nuances. And fourth, the top audit red flags.
Section 1. Defining the problem addressed.
So here's the absolute foundational rule. Just having a diagnosis listed somewhere on a patient's chart, that doesn't give you MDM credit. To actually count, the condition must be actively evaluated or treated during today's specific encounter. And notice this key detail. It also includes diagnostic or treatment options that you and the patient explicitly considered but maybe decided against after some shared decision-making. That mental work, that clinical thought process, that absolutely counts as addressing the problem.
And this brings us to a massive trap I see coders fall into all the time. Simply referencing a historical problem that's being managed by a specialist gives you 0 MDM credit unless you are actively evaluating it today. For example, if your patient comes in for a sore throat and you just copy and paste their history of osteoarthritis into the note without actually evaluating their joints, that osteoarthritis does not count toward your complexity. You have to actively manage it today to claim it today.
Section 2. The 4 problem tiers.
All right, let's start at the baseline with straightforward MDM, which involves minimal complexity. We're talking about one self-limited or minor problem that we'd expect to resolve with very little intervention. Think of someone coming in with mild cold symptoms, a basic rash, or a minor scrape. You're probably just giving them some reassurance, maybe an over-the-counter recommendation, and the risk of the condition itself is exceptionally low. Stepping up one tier, we hit low complexity. This covers a few different scenarios. It could be 2 or more of those self-limited problems we just talked about, or it could be a single, stable chronic illness. Picture a patient coming in for a routine checkup on their well-controlled hypertension, where you don't need to change any medications. Low complexity also includes acute, uncomplicated illnesses or injuries, a basic ankle sprain, or a routine case of an ear infection that just needs a standard prescription, fits perfectly right here.
Now, moderate complexity is where a huge chunk of your daily encounters are going to land. This tier handles multiple stable chronic conditions managed together, which naturally bumps up your cognitive load. It's also where you'd put a single chronic condition that's actively worsening, progressing, or maybe causing side effects. A COPD flare-up needing a steroid injection? That's moderate. An undiagnosed new problem with an uncertain prognosis, like new-onset chest pain needing an EKG and a referral? That lands squarely in moderate complexity too.
Finally, we have high complexity. This is reserved for severe immediate risks. We're looking at 1 or more chronic illnesses with severe exacerbation or progression, or a condition that poses a direct immediate threat to life or bodily function. If you're dealing with severe anaphylaxis, an acute MI, unstable angina, or a patient with uncontrolled type 2 diabetes and a severe hypoglycemic crisis, you are operating in the high complexity tier. The risk of morbidity or mortality without intense, immediate intervention is literally off the charts here.
So we just talked about stable chronic illnesses. But what actually makes a condition truly stable in the eyes of a medical auditor? This single word can shift your entire coding level.
Section 3. Key definitions and nuances. This is a massive nuance, so pay close attention. Stability is not about the patient just feeling fine or their condition remaining unchanged. According to the AMA guidelines, stability is strictly measured against whether the patient is hitting their specific, documented clinical treatment goals. Let's say your hypertension patient comes in feeling completely normal. Their blood pressure hasn't changed since their last visit, but it's consistently reading 160/100, and your documented goal for them is 130/80. By definition, that patient is not stable because they are not at their target. You absolutely have to document this explicitly.
You've also got to be crystal clear on the difference between general symptoms and systemic symptoms, because misclassifying these can wildly alter your MDM tier. Systemic symptoms will push an acute illness right up into moderate complexity, but a mild fever that comes with a common cold, that's just a general symptom of a minor illness. To claim true systemic symptoms, your documentation has to reflect a much higher severity, like severe rigors or a documented systemic inflammatory response.
And let's talk about comorbidities. A huge laundry list of underlying conditions is totally useless for your MDM unless your documentation explicitly shows how they complicated your clinical judgment today. If a patient comes in for a simple cut on their arm, their history of depression doesn't bump up your MDM. But if they have poorly controlled diabetes that forces you to change your wound care strategy and prescribe a special prophylactic antibiotic, suddenly that comorbidity is active, it's addressed, and it legitimately counts towards your complexity.
Section 4. Top Audit Red Flags. Okay, let's look at the exact compliance triggers that auditors hunt for. First, avoid carrying forward a historical problem list without showing active evaluation or a care plan today. That is a fast track to a failed audit. Second, never up-level a stable condition to exacerbated without actually documenting the clinical worsening or treatment modification. Third, don't try to pass off a routine symptom like a standard tension headache as an undiagnosed new problem with uncertain prognosis just to inflate your coding level. And finally, using vague phrases like follow up in 1 week gives you zero risk justification. If you need to see them in a week, you have to document why. What are you actually worried might happen?
It all comes back to this core principle. Medical necessity determines whether a service is justified and payable, not just whether it was performed. This is the whole overarching theme of modern E&M coding. You might have performed an incredibly comprehensive exam, but if the medical necessity of the problem you addressed only warranted a low-complexity visit, that is all you can legally and ethically bill for.
So I want to leave you with this challenge. Go back and pull your last 5 encounter notes. If an auditor reviewed them today, would your documented clinical actions definitively justify the MDM level you billed, or is there some hidden risk in your phrasing? Getting this first element right is absolutely critical for bulletproofing your practice. We're going to uncover a lot more in our next deep dive. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.